I have the valve team of ours. Dr. Sengottuvelu heads the valve team from Apollo Hospitals. And we have Dr. Anuradha with me, 3 of us here. So let's go to the history first and come back to you, Bharat. Can we have history, please?
Good afternoon, everybody.
Hello.
Our third case is a 22-year-old female who weighs 39.7 kg. She underwent transcatheter pulmonary valvotomy twice at 2 and 3 years of age.
Keep the balloon, man. Balloon.
For severe
can you hear
Annie, they can't hear you properly.
We can't hear you properly.
Hello? Hello?
Just mic, please.
You'll have to just shout into the microphone otherwise.
Hello? Good afternoon, everybody.
You can hear me, right?
Our
I
third
can hear
case
you, but not the
is a
history.
20.
You want to
Not
put the
history.
in
History they can't hear.
Anu, you just take care of the balloon. Anu,
Hello?
just take care of the balloon inflation. Now we want a coronary. Can you give me a JR?
Hello?
I'll read this.
Huh?
Pictorial protein.
Pictorial protein. Say.
Good
We don't
afternoon,
want to
everyone.
selective.
Our third case is a 22-year-old female who
Lateral.
weighs 39.7 kg.
Yeah.
Yeah, you can proceed.
She underwent balloon pulmonary She
She
underwent balloon pulmonary valvotomy twice at 2 and 3 years of age for severe valvular pulmonary
Anu, you okay?
stenosis. At
you
5
do the
years of
balloon,
age, she underwent open pulmonary valvotomy for residual PS in addition to the left hemianomalous
Okay, and the
pulmonary venous
reference image
drainage
photo can be?
repair. For progressively increasing
Lateral.
pulmonary regurgitation
overlay, three overlay,
and mild RV dilatation, she underwent RV to PA conduit implantation at 18 years of age with 18 mm contograph. For recurrent conduit stenosis, she had to undergo balloon dilatation of RV to PA conduit in August 2018 with a 20 by 40 ZMed-2 balloon. At present, she is symptomatic with dyspnea on exertion, NYHA class 2, and she has a 3 by 6 ejection systolic murmur at left second intercostal space. This is the chest X-ray of the patient, which shows no cardiomegaly and RV type of apex. The ECG shows sinus rhythm with a QRS duration of 120 milliseconds and a normal QRS axis of plus 60 degree. The echo, the 4-chamber view shows intact interventricular septum, mild RA-RV dilatation. There is a RVOT view in the parasternal long axis, which shows the stenosed and the calcified conduit, and the peak gradient across the conduit was 57 millimeters of mercury. There was a moderate conduit regurgitation. This is the RV angio in the elaeocranial and the lateral view, which shows the stenosed RV to PA conduit. In August 2018, when we did the balloon dilatation of the RV to PA conduit, so we did it with the ZMed-2 20 by 40 balloon. The CT scan of the patient, it shows that the conduit measured 28.6 millimeter in length and the maximum diameter was 21 millimeter. So the plan is that we go ahead with this patient for transcatheter pulmonary valve implantation.
Did you go for an MRI also for the cardiac function?
We didn't go for MRI, we just went with the echo. Echo, the function is good, LV function, RE function, everything is good.
And Muthu,
So,
on your CT scan, did you see any coronary artery proximal to the conduit?
no. We have done the balloon dilatation and also coronary thing. What we'll do is, we will just show step by step. Go to the angio, please, one by one play. So actually the CT scan measurements came as the widest diameter is 23 actually, the narrowest point about 14. So you can see there's a calcified conduit junction and the free PR is also significant. Go next. We did a RAO view, look at the entire RVOT. So that's the RVOT view. So the pressures, RV pressure was 60 versus aortic pressure of 110. So there's a clear indication to go for a valve here. So what we thought is we will pre-stent and then go for a valve implantation. So let's do one of the important things in a pulmonary valve implantation is you have to have a good wire position. Lentacus wire in the LPA nicely snugly fitted. So when you take a wire across into the RV, usually the lentacus comes out. What we used to do is you have to take a 7-French guide up to the MPA and then take 2 wires, both the lentacus and the thermo wire, and then cross into the LPA and push the lentacus into it. Then you can get a good position of the lentacus wire. Once the lentacus wire is in good position, you can take the valve across easily. So next one, we have taken a 18 mm
Atlas balloon.
To pre-dilate, and then we did an angiogram to look for any obstruction. At the coronaries, there is no obstruction.
Oh, good.
So now we plan to pre-stent it with a 43 mm Andromed covered stent. The reason I am using a covered stent is because you have a 18 mm conduit here. So we are going to put a 23 valve. So I don't want to have any rupture. If you have a covered stent, the rupture will be taken care of.
Muthu,
So
can
we are
I
going to
make a
use a
comment?
20 mm. Yes.
Why
Yeah.
did you go with that? Why did you go with a high pressure
Why
balloon?
did we go
Why did you go with a high pressure balloon to crack a conduit which is calcium? Why did you not pre-stent? You should have put
No,
a
the thing
covered
is we have
stent
to see,
before
sir, big.
to protect. You should have put in a covered stent before to protect that calcific conduit. I'm not saying nobody does it this way. There are people who do it this way. But in my opinion, the
Yeah.
safety of
Yeah.
the procedure is
Yes, sir.
enhanced if you put in a covered stent
So we are
first
done. We are
and
four.
then
Sir, we
prepare.
are. We,
Yeah,
so
no,
we are
no,
done.
we Dr.
Is
Bharat, we
Mahadevan
agree,
in the
but
audience?
I think here we didn't
Mahadevan?
oversize the balloon. It's only 18 mm balloon. Could have done either way.
Get the. We'll prepare the
Bharat,
stent.
this is not a homograft.
Yeah.
This is a contigra. And contigra tends to balloon out more in the middle of the conduit, and what you see is distally where it joins the pulmonary artery. There will be stenosis over there and probably some
Get it
calcification.
open.
The contigras don't tend to rupture that
Even
often
if
compared
they
to
are
homograft.
Okay.
Yeah.
Thank you.
That's why I was going to ask
Moreover,
Mahadevan,
Dr.
because
Bharat,
he's got a lot of
we-
experience
we-
in.
We have
Go on-
used
go on,
a
Muthu.
balloon 18 mm balloon before. We have used 18 mm balloon twice on this lady about 6 months to before 1 year before, nothing happened. And the reason we did this, we didn't initially thought not doing a balloon dilatation at all, but we have to show the coronary arteries. Although we have seen in the CT scan there is no problem with the coronary arteries, we have to show balloon dilatation. That's why we did the balloon dilatation of the conduit. Now we are going with the 14 French sheath, Bharat, for the sheath, for the stent. Okay, fix the wire, please.
But I think, Bharat, you were right. If it's a heavily
Okay.
calcified conduit, irrespective of whatever, you got to be careful if you're using a high pressure balloon. The risk of rupture is there. But I think here it's not that bad.
I agree. And second thing is, I agree that they have done a aortic root angiogram.
See,
But always, if you have any concerns, you
have to
have to do a
select it.
selective
Selective.
angiogram. Better to. I mean, I'm not saying it has to.
But again, that is where sometimes the pre-procedure investigation, if you do a
Absolutely.
CT scan,
A good CT scan.
and
that
see
solves
where-
a lot of problems.
Yeah.
The only issue I have, Chetan, with a CT is that CT tells you the position of the coronary with respect to the conduit before it is fully
in
dilated.
spite,
But when you dilate, more so a calcific conduit, there can be so much migration of the calcium.
That's right.
That occasionally you may, I'm not saying you.
and you can have spicules also, which
That's
can.
right. That's the concern.
Yeah. I think again, Vorakkan is not in the audience because his views would have been important.
Go to the AP first. That's a struggle of going across the RVOT. Okay,
in
fix the wire,
spite of the Lundquist wire. And yes, it's gone. It's almost gone.
That's coming out. Okay, fine.
So Muthu, can you tell us your plan in terms of what stents were you planning to use?
I'm going to put a 43 mm Andra stent, Bharat. Covered stent.
Show the stent. Show the stent. They have in the front of camera.
And you see the struggle we had to get across the RVOT. That's
Yeah.
something worrying for me. for taking the valve across.
Muthu,
That's the
with
problem with
many
the
of
particularly.
the calcific conduits, this is quite a common occurrence. It's not uncommon that you have to struggle.
Yeah.
And many times you have to
12
pull
French
back a
shorts.
little bit on the Lundaquist so that you may lose the wire position
Yeah,
a little
yeah.
bit, but it might help you,
Yeah,
get
yeah.
the sheath a little forward.
Yeah. 12
The
French shorts.
second is that if you see your
Okay, we
wire,
prepare.
it is in the inferior part, but I'm not sure how posterior it is.
Exactly.
So that is another thing that
43.
you can do, keep the wire more posteriorly. And the
Think
third thing
what?
is, you can use a small balloon, 8 or a 10 millimeter balloon instead of a dilator,
60.
and track the sheath across the calcific conduit.
Yes, yes. Cut it down.
Okay, now we are preparing the stent.
Small thread should not go in.
Are you happy that your sheet is distal enough to start going with the stent?
Yeah. Yes. We are near the LP. Actually, if you look at show the RA view, please, for them. Hey, one of you go stand there and show the RA view. Madam, RA view got it, madam.
Clear.
That is the contrast. So, what the main problem I think we're anticipating on this valve is the crossing the RVOT. As Bharat said, I'm going to push and pull on the Lundaquist to get the valve across. I hope it goes. So, what does the audience feel about the stent and all the stent, covered stent?
Ah.
We thought of using a CP stent, but it's very expensive.
Okay.
I would ideally want to use a CP stent here.
Sure.
If I may ask you, Muthu, what valve are you planning to deploy?
Yeah, we didn't present about the valve, right?
You have not spoken
Let me present about the valve.
valve.
Come on, show that. Okay, all right. Sorry.
So
I
if
thought
you are-
my
if you are
other colleague
planning
had
to put a my
done.
valve, my question to you
Yeah.
is that since it is on a cobalt chromium
Yeah.
stent, why do you want
Yeah.
to pre-stent this conduit?
Stent it, yeah.
See, it
Yeah.
is okay for
That's
melody
that
because the
I-
incidence of fractures in a non-stented conduit is much
discussed
higher
that.
in double figures. But I am not sure that for my valve, which is on a cobalt chromium stent, there has been enough data to justify pre-stenting.
But here the degree of stenosis
Bharat,
is
also we
quite
discussed
distal.
that.
I think Bharat, I understand your point.
Okay.
And the reason I used I had debate a lot of people about whether to do it without pre-stenting.
Okay.
The general consensus, Vorakan said since this 18 mm conduit, you're going to go for 23 valve. He felt putting a covered stent might help you from rupture. So if you put a covered stent in before that, then it can prevent you from rupture. That's what he said. So a couple of people felt the same who had done Sapiens valve before. So I thought using a covered stent. That's the reason.
If I would be
I
doing
also
this
lot
case,
of
I would be
people do
worried about
without
the degree of stenosis that you have, which is quite distal. And if you just go with the valve, the landing zone is quite limited. Whereas if you pre-stent it, you have
Yes.
got a longer landing zone
What
to
I
work
would
on.
do, what I would do is that after dilating it with
Yes.
Atlas, I would make another angiogram. Look at the hemodynamics. If there is a good
Yeah.
angiographic picture, a gradient of 10 millimeters across the
Then-
calcific, then I don't see any justification in putting one more stent. But I am okay with if you want to put in, that's not a bad idea. Go ahead.
Why not 20 millimeter my valve
Yeah.
rather than 23? And do you need
No,
not require
actually,
any
I-
covered stand beforehand?
The thing is, the smaller the valve, the more chances of obstruction and stenosis they say. So what they feel generally, and if you look at the melody also, the melody's problems may be because of 22 size. 23 valve is better for her long term also, and that's the reason we are using a 23 rather than 20. 20 is smaller for her.
Muthu, till such time you are getting ready with the valve,
Yes.
can somebody in the cath lab make
Yeah.
measurements of the conduit if you have made an angiogram after your Atlas dilatation, or
Yes,
you
let's
haven't
make a
made an
measurement.
angiogram so far?
We haven't made an angiogram after the balloon dilatation.
But has it not been your
We can do one. We
practice?
got a sheath across.
Yeah, because I think it is a good practice to see what you have done to a calcific conduit after dilatation, to do one
Sure,
angiogram.
sure. Give me the contrast, please.
Meanwhile, we can go to other lab and see.
If you want to go to other lab and come back also, fine, but I'll do an angio first before you go.
Do an angio quickly.
All right? I have to bring the sheath back. Huh?
Back.
Yeah, distal. Yeah, say it. Go back. Yeah, we'll do a measurement on that. Go back. Yeah. Go to RAO.
Isn't there some stenosis of the origin of the pulmonary artery to the distal conduit?
We did check all the gradients across LP, RP beforehand. There's nothing there.
My
RAO can you tell me? Yes, Bharat.
My only concern is on lateral angiogram, I thought that your sheath was not distal
Yeah.
to the tidemost portion of the stenosis.
That's right.
And there is a chance that your
Will slip
stent
back.
may not track all that easily as much as you think that it will. So I would
Let
be
me do
happy
angio
to
now
get
and
the
see, just a
sheath
second.
more distally, distal
The
to the
sheath.
stenosis. I think it is just proximal and tracking it will be a concern, Muthu. So I think you take
Yeah,
your
okay,
time.
okay.
You take your time, but get the sheath
Yeah.
distal to that obstruction and calcium.
Sure. Okay, all right. We'll do measurements also, and then I'll come back to you. All right?
Yeah.
Measurements.
Yeah. That's the.
Can you
yeah,
cut?
Yeah.
Can you
Yeah.
So let
disconnect
us-
us?
Okay.
Can we go to
Let
the
us
other lab?
move to the other lab.
Anil?
Okay. Okay.
Okay.
So a lot of people doing melody valves over here, or this is the my valve. I've never heard anything about it. It looks like an Edward Sapien to me. What is the audience experience? More melody valves or this more Edwards valve? So this my valve is what? Is it a local make? Is it? Okay. So venous valve is available here, is it? Mike. Come on, Sushil, don't feel shy. Sushil is too Sushil.
Narrows point. All right. Okay. So we have to go up to there.
Anybody has done Edward?
Sheet உள்ள எடுத்துட்டு போறீங்களா?
Edwards by now.
Shiva has done a lot of high valves.
Okay.
Approximately
34.
25
That
cases
should be
of
enough, I
high
think, no?
valve have been done percutaneous total in the country. Maximum
No.
people have
Hmm.
10, 15.
So you put the sheet back, no? The valve sheet and
We'll put
Take
a
it out.
dilator back in second.
dilator back.
We'll take this. We'll look at the wire positions again before doing the take the wire position. Wire better than.
And the my valve is to be can be
It's primarily meant for the aortic valve.
the TAVI program. Yeah.
Yeah, TAVI program. Probably Muthu has done one before. Probably his second.
And is it mounted outside the patient as you do for the melody valve?
Yes.
Because the current Edwards valve, you have to mount it inside the patient. You actually, that is one of the worries we have with the Edwards valve.
This is
That if you
mounted
don't
inside.
deploy it, you have to leave it in the IVC because you can't take it out.
I'm not sure as to whether they mounted the
Okay, can I answer that?
Yeah, please, go ahead.
Okay, see the my valve is like the Sapien Ultra. So
The old style. Yeah.
so you don't have to load it inside the body. You can take it directly, and it's loaded outside on the balloon and directly taken inside.
And it is well
The second
covered.
part is we have a
It is well covered and protected
Yeah.
so that it doesn't slip off the balloon.
By
It
the
has a
Yes,
sleeve or
excuse
something.
me.
yes, it's well covered. It is. And they have a Python sheath. The MyValve is an Indian company, made by an Indian company, and the Python sheath is an expandable sheath, like a E-sheath of Edwards. So one of the advantages of this Python sheath is, in case a valve cannot be deployed, cannot be crossed, then we can take it out through the Python sheath back through the Python sheath. So you don't have to deploy it in the IVC.
And what size of sheath are you using for this?
This is a E-sheath, so we are going to use the Python sheath comes as a 14 and 16 French. For a 23 valve, use a 14 strength E-sheath. So that is what is, the sheath expands.
So we are a nightmare. So let me go through nightmare session as we unfold. Where were you? We were before we were going to stent the RVOT.
Yeah.
So show me. That's why we had an angiogram on the RVOT. Next, please. So we decided to stent it off after long discussion about stenting and non-stenting. I just wondered why I did go for stenting. Go on next. Next, so we positioned the wire nicely deep inside and then took the sheath across. So then I took a 43 mm covered Andramed over a 20 by 60 Andramed balloon. So we thought of stenting we checked the position was right. You can see that, play that please. So the position was right. Next view please. So next view, that position is good. So there you are. We want to go for stenting. So next one. Before that, yeah, play that. As the balloon was inflating, what happened is the stent didn't inflate. There's lot of it pushed the stent up. So next please. So you can see this. We tried to take the balloon back inside. The balloon would not advance inside. So, and one more interesting happened. The balloon would not come inside the sheath also. So next one please. Next one. Next. So we tried different maneuvers to bring it inside, but it wasn't coming back. Finally we did sort of ballooning up and down, and finally, hey, go back please. Go back please. Yeah, so what we did is we inflated the balloon entirely in the RV to form the balloon back again nicely. Next one. And then we took the balloon inside the sheath. Although about 3/4 the balloon was inside, the balloon would not come in. So what I did is I took the balloon and the sheath. Next please. Next. So now you can see the balloon is 3/4 inside, but still the balloon is a deformed balloon. It won't come into the sheath, a 14 French sheath. So we took the entire thing off. Okay, next one please. So then what I did is I took a 12 mm Cook's balloon to see whether I can balloon dilate it. So as the Cook balloon started to inflate, it again the same thing. It was melon seeding up and down, but the stent would not open. Next view please. Next. Play by inflation. Yeah. So you can see if I come down, it goes up. If I go up, it comes down. So the stent would not at all, inflate at all totally. Then I took this 12/4 balloon out. Then took a Atlas balloon, 20/4. So we kept the the sheath to prevent the stent from falling back. Then we took the 20/4 Atlas. Next please. So Atlas gone in. So we position it across. Next one. Yeah. We thought of holding the balloon in one end and see whether other end opens or not. It didn't. It partially opened this end, but other end didn't open. You can see that, and now slowly we are inflating. Next view, please. Now you can see the top bit opens and pushes the stent down. Next one. And then this is like happening like a seesaw. I don't know what's wrong with the stent. The stent would not inflate whatever we do. So we have been doing this for a while. Next. Now we got the stent in center, and so we thought we could inflate the same Atlas balloon. Go on next. You see, it came up down this way rather than the stent being inflated. So we thought we should use a long balloon. This stent is a faulty stent and it's got some problem in inflation. So I thought we should use a long stent to keep the stent in position. So we thought of using a Mustang. Go next. 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 So all these maneuvers failed. Okay, next. Partially inflated lower end and it didn't really work. In this aspect, the stent moved down into the RV a bit. So next. Go back. So now we have that 80 centimeter, 80 millimeters, 12 mm diameter Mustang balloon. We did a slow inflation next. So to make sure the stent becomes center. Next. So this expanded the stent. Next. But you can see that the stent has moved down from the narrowest point where we're supposed to be doing. So we took a 20 mm Atlas balloon and inflated it. So it did inflate the narrowing, but the narrowest portion. Next, please. Next, please. Yeah. So you can see the stent move down. So it is in the RBOT and it's not covering the narrowest point. So we don't have a choice to stent above. So we took one more uncovered stent. Go next. Next. At this point we took a Andromed 43 XL over a 20 by 4 Andromed balloon. Next. Next. Okay, now we got it across the narrowest point. Then start inflate. Next. Next. Yeah. Next. So stent inflated nicely. And then we did one more dilatation low below because it's a 43 over a 40 balloon. Next. 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 So we did inflate it to 40. Again we took a 20 millimeters, 20 mm Atlas balloon and inflated maximum. Next. Next. Yeah. That's the Atlas balloon inflation. We made sure that it expands to 20 millimeters. So that's ended. I don't think it ended our nightmare. So next is a valve. Next, please. So next. And we expanded the lower bit also to allow the valve. Next one. Hello? Can you hear me?
Yeah, you are audible. We are listening to you carefully.
Can you hear? Yeah. The story was like not yet ended. So then finally I positioned the wire better. Next, please. Now you can see the wire been gone into LEAP LPA, and then we took the stent. Before, please, this one before.
Valve.
One before. Now play this. So we took a E sheet which is comes with this my valve, and the valve came along, and as usual it wasn't advancing beyond this point. Next, we did retroflex the delivery system, but still then it wasn't moving, and so I did a lot of pushing and pulling technique and bit of praying to God also I did. And then the stent moved inside. Next. 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 So we did a curvature in the RA also to see whether it will go inside, but it didn't help. So we tried whatever techniques possible. So then you see that I slightly straightened it, it went inside a bit, and then I slightly push and pull technique. I was just pushing and pulling the valve. Next. All right, then we got in position inside the nicely in the stent. Then we went for the full valve inflation. Next. So then we took the balloon off. Next.
So here, if I can ask one question.
That's an angiogram post. Yeah, just the angiogram, and then you can ask.
Okay.
I think a lot of questions will be there. I'm ready to answer every one of them. So basically, that's the end result. So let's fire with the questions.
Yeah, Dr. Suresh.
All right.
Yes, okay.
These are all the
Yes, Suresh, tell me.
experiences with my valve in the RVOT position. I just wonder whether both these cases,
Yes.
Dr. Shiva's case and Muthu's case, demonstrates a lesser trackability of my valve in the RVOT. Say even for Melody or Edwards valve, in the RVOT, it doesn't go easily. And mind you, in the instances where we put in a pulmonary valve, we have a dilated RVRA, we have some tricuspid regurgitation. It's in that setting that this is going in. I just wonder whether my valve, which is essentially designed as a TAVR valve, is not very trackable in the RVOT.
So I think the answer should come from the person who has done both, and they can tell one
Suresh,
compared to the other
Suresh,
one.
the
Yeah.
first case I did easily tracked inside. I didn't have any difficulty. We had a CP stent across it. The trick of doing it is having the stent. Here you can see some stent is hanging on into the RVOT. So that stent will not allow your valve to track properly. The first time we had a stent exactly in the pulmonary artery, and there's nothing jetting out, and it smoothly went inside. Even Edwards have the same issue, I understand. But having the wire position in deep inside LPA, you can negotiate into the RVOT. When I spoke to people who have done a lot of Sapiens valve, about 99 times out of 100 they got the valve across. So it's definitely designed for aortic position, but it does work in pulmonary valve position too. But we need to have a proper stent position before we go on.
We'll have to see how it works. We have to do more cases.
What
I
was
think.
the reason for?
Can you introduce yourself, please?
I am Dr. Adia.
No, there is a person behind.
Sir, this is Dr. Venkatesh. This is regarding
Hi,
the
Dr. Venkatesh. How are you?
Sir, this is regarding the under expansion of the stent. Do you think that this is the stent factor, or is the balloon factor, or is the stenosed contigra as such? Because once when you have expanded the stent, it looks good. I mean, with the Mustang balloon, you have dilated it, and that is looking good. Probably using a longer stent as such, probably if CP is not available, and under a longer stent, tracking it up would have expanded the initial stent, sir. But do you feel so post-hoc that taking a longer stent?
No, actually, the factor behind this is what we call in Tamil is Talavidhi. Because I have done lot of stenting with Andromed, covered and uncovered. It never happened to us. And this stent is basically a faulty stent where it doesn't expand at all. You need a lot of pressure, and you have to have it in the center. You can see that we have used stents in position in aortic position, in pulmonary position. I used 40 mm balloon. We never had this issue. So this is a covered stent, particularly Andromed. Andromed CP covered stent expands easily. So this is something I learned today, that Andromed covered stent, you should be slightly taking a longer balloon, as you said, and then go for slow inflation, because this you see that when we went for rapid inflation, it came down.
Dr. Yadav, please.
Why not directly put the valve rather than shooting the stent,
Yeah.
do you think it increases risk of fracture or what? Directly
Very good question. I was wondering halfway through it why I didn't do it, because we are thinking about it. We are discussing a lot
Because
before,
this stent doesn't
and
get
reason
fractured.
why we went.
This valve doesn't
Yes.
doesn't get
True.
fractured. We have not seen any
You,
report
you,
of
you are right, sir. You are right, sir. No, so you are right, sir. The reason why we went for it, we want to have a covering, a covered stent, because if it ruptures, it's our problem. That's the thing. Because 18 mm Contagra, we are using a 23 mm valve.
No, you can use
So
20
we thought
millimeter
we would
valve
possibly
rather
be
than
safe.
23. You can use 20.
Even
because
20 is a
is
risk,
available.
sir. Even 20 is a risk also. So we thought of using a stent.
And
So
even
the model
in
may
that
be
also,
I do
if
not
you
use
will
the
add
stent.
some slightly more in contrast, maybe 1 or 2 ml more, it will attach better.
No. Is it recommended to use without stent on the pulmonary side?
Yeah. It's
On the
it's
pulmonary
not,
side.
Yeah, it is because with the Sapien
Pulmonary-
3,
no,
it has been shown without any putting
Sapien
a
valve,
stent.
Sapien.
It's not recommended for pulmonary.
For-
No, actually, sir, for I have done about
RVOT,
50
this
IT
valve
class.
was used, not my valve, but Sapien has been used, Sapien 3,
Sir,
without
the
any
thing is, sir,
So
sir,
how
actually
much
you
time do we
using
have,
in the
Dr. Anis?
aortic valve position.
That lab is also ready.
Okay. So any
2 minutes,
last
I just finished my
question?
sentence. Basically, no, I answered the question answer just
Without
now.
a stent, my
Fracture
knowledge,
of the stent is not up.
So Dr. Muthu,
not
as we
observed in
understand
aortic
over
valve
here,
position. Yes.
as of now, placing a valve in the RVOT requires a pre-placement of stent, and you cannot put the valve
Avoid
as such.
fracture.
So maybe there
Yes.
are some
I'll tell you
exceptions,
why,
maybe
because I
some
just-
odd
2 seconds,
report,
give me
but the general understanding is
No, the
that you have
aortic
to
valve
place a
position-
scaffold before putting the valve in.
If you have enough calcium, we may get away with it. But the problem with the aortic valve position and pulmonary valve position is the pulmonary artery is very next to the chest and compressed by the chest wall easily, and fractures are more common in the pulmonary valve position. Having a stent and then frame and then putting a valve inside is much safer for stent fracture. We can't extrapolate the results of aortic valve to the pulmonary valve position
So
because
also the
there are
shape
two
of the
different
RVOT,
positions.
the native RVOT is not meant
Meant
Exactly.
for
taking
the
a valve
valves.
without something as a scaffold there.
Especially
Exactly, sir,
after
exactly.
you have had pulmonary regurgitation and that the deformed, that RVOT is very roomy, so it is not suitable for a native placement of valve. As far as we know as of today, maybe the future generation of valve will be suitable for that. So thank you, Dr. Muthu, and congratulations for the case. We'll move on to the lab in Triple M,
Thank you.
which is now ready. Thank you.
Thank you.